Good afternoon, everyone. My name is Awa Touray, and I have the distinct pleasure of welcoming you to CABRI's webinar on public health budget practices and procedures. Today, I will be joined by my colleague Ashwina Gajili, Head of Technical, but as well as public officials from the Island Republic of Seychelles, as well as the Democratic Republic of Congo, whilst we do a deep dive into public health budget practices in not only the 15 African countries that I'll be talking about in a minute, but also into those two countries that represent two very different spectrums when it comes to health outcomes as well as health financing systems. So in terms of protocol moving forward, I'd like to take you through the housekeeping rules to ensure that everybody has a seamless experience. In terms of guidelines moving forward, please note that interpretation is available. So for those of you that require French interpretation, there's an icon at the bottom of your screen that allows you an English or French option. So you can choose the language channel of your choice, and this applies to the speakers of the webinar as well. In terms of interacting during the webinar, you have available to you a chat box through which you can introduce yourself as well as connect with other participants. You may also use the chat box for technical questions and concerns. So please feel free to submit your questions through the Q&A tool as well. You may target the panelists to which you want to address a question. It may be to myself, for example, at Awa Touray or at Patricia, Rene, and we will try and get in as much questions as we can so that it's an interactive session. We look forward to some very rich discussions. I'll take this opportunity to hand over to my colleague, Ashwina Gajili, so that she can offer some opening remarks before we get into the thick of things.
Thank you, Awa, and welcome to CABRI's webinar on public health budget practices and procedures in Africa. Thank you to all our participants. It's a pleasure to see the names of many who have been attending our webinars on a regular basis, and a specific warm welcome also to our member countries and partners. Over the years, CABRI's work in the health sector has focused on several topics such as funding mechanisms, how to strengthen link between ministries of finance and health, the complementary roles of different actors in the policy and budget cycles, and value for money consideration in health spending. Some of our work have been more country-specific, such as health financing in maternal and child health in Ghana, or as part of our Building PFM program in Nigeria. Today's webinar will tackle the theme of budgeting for healthcare amidst resource constraints in Africa. It will prompt hopefully discussion on how to engage stakeholders in budget preparation and the prerequisite for an efficient budget elaboration and approval process. We have seen how in many countries in Africa and worldwide, the consequences of not doing so means that health policies, planning and budgeting are not aligned, leading to dysfunctions in the health systems. In countries which are already resource constrained, such situation can only exacerbate the lack of quality services to the populations. The context of this report is unique. According to the latest figures published by the Johns Hopkins University, we are nearing some 5 million cases of COVID-19 worldwide, with more than 300,000 deaths. In Africa, we have over 90,000 confirmed cases and almost 3,000 deaths. The pandemic sheds light on the legal framework that impacts budget formulation and execution, on how ministries of finance are dealing with reallocation of funds, how they are defining the immediate spending actions that can be taken within the existing budgets, and how they are accelerating budget execution and funds to be able to fast track purchase of medical supplies. A health budget is more than just a financial tool to present revenues and expenses. Instead, it is a critical guiding instrument which demonstrates a country's key financial capacity and its commitment to implementing its health policies and strategies. The health expenditure as a percentage of GDP for sub-Saharan Africa is slightly above 5% compared to the 9.9% world average. And while in 2001, African leaders have pledged to invest around 15% of their budget in health, by 2020, only 5 countries have been able to meet this target. The COVID-19 has made investment in health even more urgent. While government expenditure for health has increased for most countries, in some countries, there has been a prioritization away from health in government budgets, with the private sector and donor contribution to the health system growing. My colleague Awa will go over the details of the health budget reform report that confirms such trends. The impact of a strong health system on economic development are clearly established. Economic evidence shows that 10% improvement in life expectancy at birth is associated with the rise in economic growth of some 0.3 to 0.4 percentage points a year. The CABRI Public Health Budget Report that we are pleased to launch today will cover 15 countries and was held over the second half of 2019. The aim was to provide African governments with information on budget processes within different countries as a point of reference for the implementation of budget reforms. But more than just making data available, we are hoping we can facilitate peer-to-peer conversation between countries with similar challenges, who will then be able to work towards a more efficient budget execution, decrease areas for payment of goods and services in healthcare, and capture donor support to improve budget execution reporting more accurately. With or without a health crisis, robust data and monitoring of government health spending are critical. When the context is not the same, we're hoping officials from different governments will scrutinize the report and hold discussions for innovative approach to budget planning and execution. The report will provide a unique insight on allocation and expenditure to public health interventions, on the institutional arrangements that shape public health financing considerations and coordination, and on financing and budgeting for water, sanitation, and hygiene. We will be hearing more later from 2 participating countries, namely the Democratic Republic of Congo and Seychelles. I would like here to acknowledge the contribution from the other participating countries, which are Benin, Cameroon, Chad, Côte d'Ivoire, the Gambia, Guinea Bissau, Lesotho, Liberia, Mauritius, Nigeria, Sierra Leone, South Africa, and Uganda. I now have the pleasure to invite my colleague to present the key findings of the report. Awa, over to you.
Thank you, Ashvina. Before I get into the findings of the survey proper, I'd like to provide some context into the state of global health in African countries. If you look at maternal and newborn, child and adolescent health, there is an under 5 mortality rate of 76 per 1,000 life births. If you look at HIV, AIDS, and TB, Africa accounts for a quarter of these cases globally. 417,000 people died in 2016. If you look at sexual and reproductive health, only 53% of people in Africa have access. When you look at non-communicable diseases, the WHO projects a 27% increase in cases in the African region alone. So this paints a situation, aside from COVID-19, that requires that resources are not only channeled to the sector, or that the sector is funded sufficiently, but that they're allocated in a way that ensures value for money and that contributes to health outcomes. If you look at allocation to the sector, when you look at the average per GDP within the respondent countries, compared to to the African average of 5%, but this is significantly lower than the global average of 10%. So there is still very limited funding that is being allocated to the sector. In 2001, African countries pledged to allocate 15% of their budgets, to the health sector. By 2010, about 18 countries had actually allocated even lower than they had allocated at the time of signing the Abuja Declaration. So this provides a lot of context into why it is important that public health budget practices and procedures in Africa drive resource allocation in a way that contributes to a healthy society within our African countries. So I'll delve into the research proper. About the report. So we launched this survey, as Shirina alluded to, in the second half of 2019, with one key purpose: to provide useful insights into public health budget processes in order to inform policy considerations around financing and expenditure management in the sector, and probe three key issues: allocation and expenditure to public health interventions in Africa, the types of institutional arrangements that shape public health financing considerations and coordination, and financing and budgeting for WASH, financing and budgeting for hygiene. And I think this is something that has become even more salient in light of the current pandemic. In terms of the process of the survey, we had 5 key phases. CABRI initially communicated to all African countries and invited them to participate in the survey. The survey was unique in that we were not only speaking to health or finance officials, but we invited focal points from both ministries. In some countries, health officials were selected, others finance officials, but certain countries also elected to have focal points from both. So that is interesting in that some of the findings of the report differentiate based on who it is that you're speaking to, particularly when you're talking about who is to blame for underspending or certain allocation issues within the sector. We launched the survey in the second half of 2019, and countries completed, 15 countries completed the survey. Country responses were reviewed, and a validation process was conducted in collaboration with country focal points, and also reviewing available literature on the health financing system of responding countries. The survey was then, data was consolidated for analysis, and the draft report was then circulated back to countries for consultation and feedback. And it was through this process that we were able to develop the final publication that we are launching today. What type of information about health financing does the report highlight? We're looking at several issues: basic characteristics of health systems. So this includes the structure of health financing systems, coverage arrangements, and so forth. Health budget formulation, the budget process, decision-making, coordination mechanisms, but general budget allocation for health. We're also looking at health budget execution, institutional arrangements, institutional structures of health purchases. We're also looking at budget monitoring. What are the mechanisms for monitoring the health budget in African countries? And then we're also looking at ODA for health. A lot of African countries are grappling with the issue of sustainability and not having enough fiscal space to allocate additional resources to the sector. So a lot of countries are heavily on donor funding in order to carry out a lot of their programs within the sector. So in terms of the country respondents, we realize that there's a lot of heterogeneity in terms of health and socioeconomic conditions. If you look at life expectancy. The average life expectancy in the sample is 60.6 years, which is close to the African average of 61.2 years, but significantly lower than the global average of 72 years. In terms of population, we have two spectrums represented in the survey. We have the two island nations of Seychelles and Mauritius with small population. On the other spectrum, we have Nigeria, the most populous country in Africa. In terms of GDP per capita, as of 2018, 15,914, while the average of sub-Saharan Africa was 3,536. The average in the sample is, however, 5,054, about 65% higher than the average for sub-Saharan Africa. The two island nations, the Seychelles and Mauritius, have small populations. In terms of income inequality, South Africa is the most unequal economy in the world, reflected in a high Gini coefficient. So how do African countries budget for health? So most of the countries in the survey have 100% of the health expenditures in their central government budget, whilst only part of the health budget is reflected in countries such as Guinea, Guinea Bissau, Nigeria, and South Africa. So this is because, so if you look at countries like South Africa, the health budget is represented at the provincial level as well, in Nigeria at the federal state level. So in terms of how expenditure levels are set and how the formulation process is set, 67% of the countries have a central budget authority, usually the Ministry of Finance, which sets expenditure levels. So in terms of the country, how this evolves in some of the countries in Chad, the expenditure of all sectoral ministries and institutions is centralized by the Ministry of Finance, and in particular by the General Directorate of Budget Services. In terms of budget preparation, the General Budget Directorate allocates envelopes to the medium-term framework, expenditure framework that each sectoral ministry will adapt in its budget. Subsequently, the ministry concerned, including that of health, allocates these budgetary envelopes in accordance with needs. That's personnel, goods and services, transfers and subsidies, and so forth. Coordination, so how does coordination happen within the sector? In 80% of the respondent countries, there is a specific body that coordinates the budget process within the health sector. In terms of the relationship with civil society, and their role is increasingly becoming prominent in Africa, and that they articulate the needs of society. 47% of the respondents have a mechanism to coordinate these activities. In terms of a focus on preventative mechanisms, 67% of the respondent countries reported that they have a specific body that focuses on prophylactic treatment. If you look at the case of the Democratic Republic of Congo, there's several thematic task forces, including 6 thematic technical commissions, bringing together 20 to 30 members from various departments. These groups meet at least once a month. These technical commissions meet in a technical coordination committee at least once a quarter under the chairmanship of the Secretary General for Health. A national steering committee then brings together public health actors from the central level and from the provinces, including technical partners and financial partners, as well as civil society. And these meet once or twice a year under the chairmanship of the Minister of Health. If one were talking about medium-term budgeting, nearly all the countries said that they had an MTEF, except for Guinea Bissau. But 2/3 of the respondent countries reported that they provide allocations based on the prevention of specific diseases, which is key in the case of Africa. And each of these countries use these categories as a basis for budget appropriation itself. And why is this significant? Allocations to specific diseases allow health officials to move funds within budgets during the fiscal year. And if there's no need to go through environment process there's no need then to go through environment process to reallocate funding across different types of costs. So this flexibility can lead to a quicker response to health crises. So in terms of the different actors that play a role in the sector, Parliament plays an important role in the budget process by setting rules relating to the reallocation of funds from specific line items. However, challenges remain. If you look at what some of the common challenges are that parliaments face, one is insufficient time to review the budget formulation document. This is something that has come across as we've worked with country teams using the PDIA approach. Lack of clear rules distinguishing the functions of the executive and the legislature in the budget process. Lack of functional oversight of budget execution reports. In CABRI's work, we've realized that sometimes even access to these reports is a challenge for parliamentarians. And then the lack of specialized staff to support budget committees. I think our work has also shown that there's often a significant capacity gap in these parliamentary budget committees that allow them to properly scrutinize the budget. So in terms of performance-based budgeting, in 2013, a CABRI study showcased that 80% of African countries had committed work implementing performance and program-based budgeting, but none had fully implemented the system. By 2018, a number of other countries were in the process of adopting performance-based budgeting. Burkina Faso, for instance, as part of the YMU directives, or the commitments through the YMU directives, but countries have since reported many challenges in implementing this reform, including issues around data, capacity gaps, lack of buy-in from sectoral ministries, issues articulating indicators, and so forth. Outside of the YMU, the Seychelles has been implementing PBB in a staggered fashion. As of 2015, they had started education in agriculture and fisheries, but with the intention of extending to government by 2017. By 2018, Seychelles had indeed fully rolled out program-based budgeting. Had fully rolled out program-based budgeting, but in our survey, they acknowledge that they are yet to fully appreciate the benefits of the reform within the sector. So in terms of budget execution, government is the main provider of practically all types of healthcare. Government is the provider of practically all types of healthcare services, while the central government is usually the main channel. Some countries, however, do delegate healthcare functions to regional and local governments. So if you look at the data that we've been able to collect in terms of inpatient care, the central government accounts for about 8%. Leaving space for regional state governments, local municipal governments, social health insurance schemes, private private health and private health insurance. So in terms of procurement, a huge chunk of the health budget is consumed through the procurement process. So in terms of value for money considerations, in terms of accessibility and equity, the type of model that countries use is particularly salient. Within the country respondents, the most common practice among the surveyed countries is through a tender process. So about 8 countries practice this. In 5 other countries, prices are regulated. Seychelles is the only country to use individual negotiations to determine prices. Perhaps they can get into this during the discussion later on. However, no countries use market prices for pharmaceuticals. These results hold for pharmaceuticals dispensed in hospitals as well as those dispensed in the community. So in terms of procurement, countries really do need to balance different priorities in pharmaceutical procurement. As recent global and regional disease outbreaks show, procurement systems need to be able to respond to large-scale pandemics such as Ebola and currently COVID-19. So what are the priorities that you need to consider in pharmaceutical procurement? One is keeping costs affordable, the quality of generic and innovation, and improving equitable access, as well as encouraging appropriate use of medicines. In terms of budget monitoring, budget monitoring is a key part of not only ensuring that it's a key part of ensuring that funds within the sector are utilized in the manner that they were intended. So if you're looking at different practices within countries, there are different actors that play a role here. So there's Parliament, Cabinet, Ministry of Finance, and the Ministry of Health. It is only in the Gambia that the Ministry of Finance doesn't play a particularly salient role in the monitoring of health expenditure. So in terms of the tools that are being utilized in these countries, it's typically the IFMIS through the IFMIS system or an Excel budget monitoring tool. Chad is, however, the only country that does not have a mechanism for monitoring budgets. In 53%, so in terms of monitoring these budgets, the time it takes for data or information on health expenditure to be available is key for countries to be able to make decisions around reprioritization of how the budget is being used within the budget cycle. So the period, within the countries that responded to this part of the survey, 2 countries mentioned that it could take 7 months to a year to get a hold of this information. About 4 countries mentioned that it could take 3 to 6 months. About 2 countries between 1 to 2 months, and about half of the respondents mentioned that it takes less than a month. So in terms of what is really causing these delays, in Nigeria, delays are caused by audits, which can take up to more than 6 months. In Lesotho, delays of 3 months is reported by the Ministry of Health. Liberia, delays of 3 to 6 months. In Cote d'Ivoire, there are a number of explanations, and these explanations differ based on whether you're talking to a Ministry of Health official or not. And lastly, in terms of funding to the sector, what is the role of ODA? In terms of the magnitude of donor assistance to the donor assistance for health, about 3 to 4 countries within the survey have over 30% of their budgets being funded through external assistance. Countries such as Côte d'Ivoire, the DRC, the Gambia, and so forth. So these has implications in terms of the sustainability of the sector and the priorities that are indeed being funded. But despite the high level, so there seems to be a lot of government awareness of the amount of funds that countries are receiving for use within the sector. So about 79% of the countries said that they were aware and had full information on the amounts of funds committed and disbursed by international institutions. However, less than 25% of development assistance for health is being managed through the PFM system in 70% of the countries. This indicates that aid is not sufficiently accounted for in government budgets for health. So in terms of managing these funds from external sources, there are various policies that exist that provide guidelines for donors when dealing with government. So the types of policies that you see in a lot of aid management policies include issues that deal with the distribution of responsibilities within government, guidelines for donors when dealing with government, preferences for aid types, preferences for aid modalities, specific guidelines for each aid modality, requirements for provision of information by donors, and M&E arrangements for aid management policies. This brings us to the end of the presentation. Thank you for your kind attention. Please keep safe and wash your hands. In terms of the report itself, we have, this should be made available at the end of this webinar on the CABRI website. So the publications consist of a main report on public health budget practices and procedures. It's a consolidation of the findings of all 15 countries, but also country-specific case studies. So we're looking at WASH financing or budgeting for WASH in the Gambia. We're looking at a comparative case study on the procurement of drugs and medicines in Seychelles, Nigeria, and South Africa. And we're also looking at budget execution in South Africa. So please go to the CABRI website, and on all reports in French, English, and Portuguese. Now this takes me to the next part of this webinar, which will require me to invite our various team panelists. So I will start by introducing the 4 panelists that we're to. I'll start with Seychelles, representing Seychelles, Ms. Patricia. She's the Chief Allied Health Officer in the PSS Secretariat. She holds several hats as chairperson of the Allied Health Council of Seychelles, but also as a focal person for the National Health Accounts. And then next to Mrs. Rene is Dr. Emelyn Shroff. She's the Director of Research at the Public Health Authority. Her research work focuses on generating appropriate knowledge for evidence-based decision making. She's also a member of the National Health Account. From the DRC, we have Mr. Raphael Nunga. He's the public health expert in charge of macroeconomic studies and sector analysis within the studies and planning management of the Ministry of Health. He's accompanied by his colleague, Mr. Ntambwe. He's head of the office in charge of budget allocations for various government ministries, including the Ministry of Health, the budget preparation and monitoring department within the Ministry of Budget. So without further ado, we'll start the discussion with Seychelles. And the theme for Seychelles is really how they've been able to leverage public health expenditure for better health outcomes. So we'll start with an introductory brief by Seychelles. They'll be giving us a general overview of health outcomes in the country, key successes and challenges, allocation to the sector, and the policy framework that currently informs budgeting and financing decisions. I welcome Seychelles to intervene.
So thank you so much, Awa, for your presentation. It was very informative. We enjoy reading the report also. We're very pleased that Seychelles has been chosen as a country to share our experience with you. So the way we're going to structure this, I'll give a brief introduction on some of our successes and also areas that we have to work on, and then Mrs. Rene will talk a little bit more in terms of explanation on how, you know, the budget is managed here. So for Seychelles, we are a very small country, so in that aspect, it is very unique. And but what has provided us over the years with good outcome is the constant investment in health and the constant commitment to invest in health over the years. And so with this, we've seen the build of infrastructure, we've seen investment in manpower, and we've also conducted analysis and surveys to see where we are with what has grown in health over the years. So we see that Seychelles people have very good access to health, and this we've evaluated it through looking at for example, number of health facilities per 10,000 population, which gives us a value of 2.6, which is above what the WHO recommendation is. We've, in terms of health workforce, it's double the recommendation of 25 health workers per 10,000 population. So we've seen some key successes in these areas, which allow people to have access. So for instance, we're close to 6 visits per capita per year. We've also seen with these investments that it has resulted in very good outcome indicators. For example, when we look at our infant mortality, it's low, maternal mortality is low. We've definitely achieved universal health coverage. Our vaccination coverage is also very high at 99%. We have very good collaboration with also the private sector, and the private sector is also investing a lot in healthcare in the Seychelles. But with our analysis, and also when we try to compare ourselves to the rest of the world, we've seen that in terms of areas of quality of health, that there is improvement that needs to happen for our health system. So this is where financing in health needs to divert a bit more attention so that we can achieve this higher quality of health. We've done some analysis whereby we've compared indicators to OECD countries. And although we've done well in certain areas, but there's still areas where our performance is not where we would like to see it. We've also done surveys in looking at the patient safety, for example, using WHO tools, patient situational analysis. And again, we've seen the need to build more structure to allow for better, stronger monitoring process, better monitoring and evaluation process needs to take place. So these are areas where we need to strengthen despite a lot of success that we've had so far in the health delivery. So Mrs. Rene will go a little bit over the process of health financing in Seychelles, and we'll chime in, we'll both contribute as we go along.
Good evening, it's me, Patricia, Rene, and thank you once again for inviting us. I'm going to talk a little bit about the budget process. First of all, as you mentioned, the main provider for the funds allocated to health is government. And actually, it's about 75%. And of the total health budget, government allocates 12% towards health. The Constitution of Seychelles guarantees free health care to all its citizens. And when I say free health care, it includes from primary health care to tertiary care, even for overseas treatment, because we don't have all facilities here, But should there be a need for very specialized surgery, government will cater for that, for the cost, by sending the patient or the person who requires the surgery overseas. Of course, the funds for health is being financed through taxation. And as you rightly mentioned, in 2017, we embarked on the on the program performance-based budgeting. And this has its up and down, because we are yet to really evaluate the full success of such an endeavor. And our budget, the way it is done, it's from a bottom-up approach. By this I mean it's the Ministry of Health and its entities who has to prepare all the proposals, the requirements for the next year's budget. And based on that, the proposal is sent to the Ministry of Finance, who assesses the situation and puts everything down on paper to be sent to Cabinet. The Cabinet of Ministers will go through, and based on the country's revenue and availability of funds, this will be approved and the necessary adjustment will be made, and then it will be sent to the National Assembly for final approval, but also in a way to monitor that funds are being rightly allocated. Yes, but at the same time, once the budget is approved, we have regular quarterly meetings whereby the officers of the Ministry of Finance will sit with the officers of the Ministry of Health to evaluate the performance and the funds used or not used, and if necessary, it will be redistributed within the health sector. Okay. The total health expenditure as a proportion of the GDP is 6% in 2019. This is the public and the private together. It's the total health expenditure. Whereas for the total government health expenditure, it represents 4%. The average of total government budget towards health is, as I've said, 12%, and this comes to about $750 US per capita. This is for government. But if we put the total both government and public together, it comes to about $910, $911 per capita. Okay. Well, this is mainly for the budget processes. I don't know if you have anything you want to add, Emelyn, or we will take questions afterwards. Thank you.
In terms of the flexibility and funds movement from different areas, want to mention something?
Well, with regards to the flexibility of funds from different areas, there is always the possibility of variance, especially since we have quarterly meetings. And should there be a need, there is always the possibility of considering or requesting a supplementary budget. And there has been instances whereby this was.
In terms of accountability, the accounts are audited on a yearly basis. But also during the budget presentation, we have the National Assembly, which really goes through every detail of the budget and really questions, the usage of funds in different areas and allocation of budget for different programs. So this is really scrutinized at that level to very, very detailed amount of dollar amount or rupee amount.
Okay.
We'll save others for if you have any questions, or we can always come in towards the end.
Okay, thank you. So I'll move on to the DRC to also provide their introductory brief before we start off some of the discussions. Monsieur Nunga.
Oui, merci beaucoup pour la parole que vous venez de nous passer, moi et mon collègue du ministère du Budget. Et pour la RDC, c'était juste pour vous présenter prochainement le pays, ou sommairement le pays. C'est un pays qui comprend presque 2345 000 km². Sa population estimée en 2015 est autour de 85 millions, avec un taux d'accroissement de 3,3%. Et la large majorité de la population est constituée de jeunes gens, donc des jeunes âgés de moins de 15 ans qui sont autour de 46% de la population totale. Alors, le système de santé est organisé à 3 niveaux. Il y a le niveau central, il y a tout ce qui est le cabinet des ministres, secrétaire général et direction centrale. Il y a les provinces, où on trouve aussi un ministère en charge de la santé dans les provinces. C'est ce que nous appelons les divisions provinciales de la santé et l'inspection provinciale de la santé pour le suivi. Et il y a les niveaux opérationnels, que nous appelons les zones de santé ou les districts de santé. C'est là où se trouvent les hôpitaux ainsi que les centres de santé. Et pour le moment, le pays compte presque 393 hôpitaux généraux de référence et près de 8400 centres de santé. Les hôpitaux et centres de santé appartiennent soit à l'État, soit aux églises, donc confessionnelles, soit aux privés, des privés lucratifs ou sans but lucratif. Alors, pour ce qui est de l'utilisation des services de santé, le taux d'utilisation est autour de 45% à cause de nombreuses difficultés d'accessibilité géographique que rencontre certaines populations, et même aussi à cause des inégalités économiques. Il peut parfois que 82% de la population vit en dessous du seuil de la pauvreté, et cette population a difficile à accéder aux soins de santé. Peut-être que les indicateurs de santé, l'espérance de vie est autour de 60 ans, le taux de mortalité de moins de 5 ans est de 70 pour 1000. Ce sont les chiffres les plus récents en 2018. Puisqu'en 2010, on était à 154 pour 1000 et en 2014, on était à 104. Donc maintenant, ça a régressé à 70. Le taux de mortalité néonatale est autour de 28%, pardon, 28 pour 1000. Et la létalité hospitalière est passée de 2% en 2016 à 1% en 2018. Alors, pour ce qui est peut-être de l'élaboration du budget, pour préparer le budget, avant tout, nous recevons, au ministère de la Santé, comme dans les autres ministères, des instructions qui sont envoyées par le ministère du budget, qui sont faites en RDC. Le ministère des Finances est séparé du ministère du budget. Donc, ce sont deux ministères différents. Du moins, c'est le ministère du budget qui dirige les processus d'élaboration du budget, des programmes budgétaires. Ils envoient des directives et ils envoient aussi des plafonds indicatifs, c'est-à-dire les crédits que chaque service pourrait bénéficier en tenant compte du cadrage macroéconomique. Alors, sur base de ces crédits indicatifs et directives envoyées par le ministère du Budget, les ministères, dont la santé, préparent les prévisions budgétaires. Ces prévisions budgétaires sont élaborées par une commission qu'on appelle souvent unité budgétaire, qui comprend, à part les services de la santé, dont la DAF de la direction administrative et financière et la DEP, la société de planification, mais cette unité aussi comprend des représentants de la société civile qui veulent s'assurer qu'effectivement le budget est préparé en tenant compte des besoins de la population. Alors, une fois le budget est élaboré, il est envoyé au ministère du budget qui consolide avec les prévisions d'autres ministères et organise des conférences budgétaires. C'est un séminaire de défense des prévisions budgétaires de chaque secteur. Après cette étape, le ministère du budget prépare un projet de loi de finances qui est envoyé au gouvernement, défendu devant le gouvernement par les ministres du budget. Et une fois adopté au Conseil des ministres, ce projet de finances est envoyé au Parlement, qui est l'autorité budgétaire. Et c'est le Premier ministre lui-même qui présente ce projet de loi de finances devant les parlementaires. Après discussion et débat, le Parlement adopte ce projet de loi de finances et les soumet à la signature du président de la République qui les promulgue sous forme de loi de finances. Ça, c'est du point de vue élaboration du budget. Maintenant, du point de vue exécution, chaque trimestre, les ministères des Finances et du Budget préparent ce qu'on appelle les plans d'engagement budgétaire. Ce plan d'engagement budgétaire est fondé sur les plans de trésorerie, c'est-à-dire sur les ressources qui sont disponibles au trésor public. Partant de ce plan d'engagement budgétaire, les différents services préparent des bons d'engagement qui sont signés par les ministres sectoriels. Ces bons d'engagement sont analysés dans la phase de liquidation par le ministère du budget pour s'assurer que le montant sollicité par les services sont inscrits au budget, dans la loi des finances, qui sont conformes aussi aux prévisions qui ont été présentées ou aux articles pour lesquels ce montant a été accepté. Une fois que le ministère du budget termine l'analyse de la liquidation, le document est envoyé au ministère des Finances, qui, une fois encore, examine la disponibilité de crédit pour la ligne de fonds sollicitée. Et si tout est OK, il ordonne le paiement. Et le paiement est effectué par la Banque centrale, soit sous forme de OPI, c'est-à-dire ordre de paiement informatisé, ou bien à travers les comptables publics de l'État dans chaque secteur. Alors, pour ce qui est de l'évolution des allocations exécution entre 2016 et 2019, en 2016, le budget de la santé, toutes sources confondues, c'est-à-dire budget sur ressources propres et sur ressources extérieures, s'élevait à 6,6% du budget national. Dans l'exécution, 98% de ce budget a été exécuté. En 2017, l'allocation pour la santé était de 7,7%, mais l'exécution était de 52%. En 2018, l'allocation était de 7,6%, l'exécution de 54%, et en 2019, l'allocation était de 10,6%, mais l'exécution de 58%. Donc, il ressort que le taux d'exécution est très faible. C'est très faible et souvent, quand c'est exécuté, 70% à 75% du montant exécuté et surtout pour la rémunération du personnel. Ainsi, le ministère dépend beaucoup de l'aide publique au développement de partenaires publics et financiers pour ce qui est des investissements, que ce soit pour les constructions, pour les équipements ou pour l'achat des médicaments. Donc, on dépend beaucoup du financement extérieur. C'est une grande faiblesse. Donc, plusieurs problèmes affectent l'exécution du budget alloué par l'État au ministère de la Santé. Il y a une faible proportion du montant des dépenses totales de la santé. Il y a les très bas niveaux d'allocation des ressources publiques. Il y a une efficience des dépenses publiques internes tout comme externes. Il y a aussi un taux très élevé de dépenses catastrophiques supportées par les ménages. Puisqu'en fait, quand nous analysons le source de financement de façon générale dans le secteur de la santé, pratiquement 40% du financement provient des ménages, et par la consommation des services de santé par les ménages. 42% provient du financement extérieur. L'État n'intervient qu'autour de 8%, 10%, et le reste, c'est par le privé. Et dans le financement des ménages, pratiquement 92% des financements sont supportés par paiement direct, out-of-pocket payment, par les ménages. Ce qui pose des problèmes pour que les ménages puissent bien utiliser les services de santé. Alors, quelles sont les perspectives pour améliorer le financement de la santé? Il y a un certain nombre d'outils qui sont en cours d'utilisation. Le pays est en train de basculer, précisément le ministère de la Santé est en train de passer du budget de moyens à l'approche budget programme. On est encore dans la phase de changement entre l'approche budget de moyens à l'approche budget programme. Il y a une loi de finances qui porte sur la réforme des finances publiques qui existe depuis 2011. Cette loi prévoit, entre autres, la déconcentration de l'ordonnancement, de manière que chaque ministère, ou chaque ministre précisément, ou chaque responsable d'un service public, soit responsable de l'exécution des crédits qui sont alloués par l'État. Il y a aussi nécessité d'informatiser la gestion des finances publiques. Et tous les ministères comptent dans leur sein un service qui est la DAF, la Direction administrative et financière. Il y a aussi un service qui s'occupe de la passation des marchés. Alors, les grands problèmes que nous avons aussi, c'est le problème d'actualiser la cartographie des financements extérieurs. Pour le moment, nous sommes tentés de travailler sur cette cartographie des financements extérieurs. On veut aussi renforcer le rôle du contrôle citoyen de la société civile, puisque la société civile intervient dans la phase de l'élaboration, mais de plus en plus, la société civile joue aussi un rôle important dans la phase de suivi de l'exécution correcte des crédits alloués au ministère de la Santé. Nous préparons aussi chaque année, depuis 2017, un rapport annuel de performance par rapport au crédit qui a été alloué au secteur pour montrer comment ces crédits ont été utilisés pour mettre en œuvre les activités du ministère de la Santé. Le gouvernement aussi a mis en place un service important qui porte sur la lutte contre la corruption et la mégestion des deniers publics. Il y a un conseiller spécial qui a été désigné au niveau de la présidence de la République afin de renforcer la lutte contre la corruption et la mégestion des finances publiques. Alors, au niveau du secteur de la santé, pour bien suivre le financement qui provient des partenaires, qui est un financement très important, nous avons introduit ce que nous appelons le contrat unique, c'est-à-dire sur base d'une planification commune avec tous les partenaires à tous les niveaux, depuis le niveau central jusqu'au niveau des zones de santé. On demande à chaque partenaire de dire clairement qu'est-ce qu'il va apporter pour la mise en œuvre du plan national de protection sanitaire, qu'est-ce qu'il va apporter, dans quel programme il va intervenir, dans quelle province il va intervenir et pour quel montant. Et cela à tous les niveaux, de sorte qu'on puisse savoir ce que chacun a fait. En fait là-bas, on travaille sur la redevabilité des uns et des autres, aussi bien du secteur public que des partenaires, afin que chacun puisse effectivement contribuer à la réalisation des activités ou à la mise en œuvre du programme qui est en cours d'exécution. Voilà donc en gros ce que je peux dire en introduction sur la situation sanitaire de la RDC, sur les processus de préparation du budget et la manière dont ce budget est exécuté. Je vous remercie.
Thank you, Mr. Nunga. I think you highlighted a lot of challenges that a lot of African finance and health ministries can relate to. In the interest of time, I think I'll take some questions from audience. There's a question on program-based budgeting. Perhaps this can be addressed to Seychelles. Program-based budgeting is a budgeting system whereby funds are allocated by program. A part of this reform is meant to include the addition of performance metrics. However, in reality, many African countries have not been able to effectively manage budget allocations on performance metrics, given to data and political pressure. How is Seychelles dealing with it? Also, one of the challenges in adopting PBB in African countries is the issue of inequality. Some facilities lack basic infrastructure, which means performance-based budgeting would increase health inequality of health services across the country based on certain underlying factors which hinder performance. How can performance-based budgeting get implemented without punishing those facilities which lack basic infrastructure?
Thank you for the question. First of all, Seychelles is still in its infantry stage with performance with PPBB. We piloted the PPBB for the Ministry of Health in 2017, and in 2018 we went to full PPBB. How it is run is whereby the different entities of the Ministry of Health, they had to have specific programs developed for specific entities, and based on that, then they develop the different strategies, the different goals they want to achieve and have specific targets. And according to that, then the funds are allocated according to specific programs. But as I've mentioned, there is regular review of the performance. Every quarter, we have to produce a specific report based on how we have been doing and whether we are on track with our objectives, our aims, or whether we want to reconsider the main objective or the goal. But the main programs is there because it has been decided for the year, and we can always revise the target or the goal if we see that it is not attainable. This is how we, well, this is to answer the first question, but as I've said, it's still a major challenge for us, and we have yet to appreciate its value. With regards to countries faced with difficulties in infrastructure, the PPBB is a shared way of budgeting because on its own, Ministry of Health will not be able to implement full PPBB. We need the backing of the Ministry of Finance, whereby funds are being monitored and appropriate guidance are provided. So I suppose for countries which are faced with problems with infrastructure, there is a need maybe to have specific programs oriented whereby on what they want to achieve with regards to infrastructure and specific goals, specific objectives, and get necessary funds maybe from the Ministry of Finance to slowly move towards improving their infrastructure. But this is something that will not come in one go, it will not come in one year. It's very important to stagger the funds and to stagger the progress, but also to monitor where the fund is being allocated and whether it is being put to good use and whether there is any improvement on the infrastructure side. Thank you.
Thank you, Ms. Rene. I'll throw this question at the DRC. This individual mentions that the budget for nutrition is quite low in Mali. And I think this speaks to the issue of how countries grapple to prioritize even within the sector. So what are those issues that you do prioritize? So according to budget analysis and methodology of the Sun, only 1% of the health budget goes to nutrition. So what is, according to you, the most operational and less burdensome approach to make nutrition a priority in the health budget? So maybe you can speak on how you prioritize within the health budget within the DRC. What are some of the considerations?
Oui, effectivement, la nutrition, bien que la nutrition soit inscrite au budget de l'État, les crédits qui sont alloués sont souvent très, très faibles, en dessous de 1% du budget global du secteur. Et même ce montant qui est alloué est difficilement exécuté. La plupart du temps, si on veut faire des actions de nutrition dans le pays, il faut compter vraiment sur les financements extérieurs. L'État ne prend en charge que la rémunération du personnel, des nutritionnistes ou tous les agents qui sont dans le programme de nutrition. Côté vraiment investissement par l'État ou achat des intrants de nutrition par l'État, c'est très faible. On dépend beaucoup plus des financements extérieurs, que ce soit l'UNICEF, la Banque mondiale ou le PAM. Il pose un problème tout justement, puisque avec une telle approche, on ne peut pas facilement lutter contre la malnutrition. Bon, évidemment, il y a aussi la part de la communauté qui n'est pas à négliger, puisque à travers les sensibilisations qui sont faites dans la communauté, on demande à la communauté d'investir un peu pour améliorer les apports nutritionnels dans leurs ménages. Donc, si on peut chiffrer cela, ça pourrait faire des choses, mais du moins, du point de vue budget, c'est beaucoup plus le budget qui est apporté par les ressources extérieures. Oui, Awa, ça je termine.
Thank you. I'll throw another question that has just come forth, Monsieur Nunga and Ntambwe. I think both countries can respond to this. Are either of the countries able to share in what ways procurement processes have been amended or streamlined during the current pandemic? And for the DRC, particularly during the height of the Ebola pandemic? And are these amendments approved by Parliament? Are they made transparent to the public? Would you please elaborate on this?
Well, we'll start. So, I mean, we can share our experience right now with the current COVID pandemic. So the whole national budget has been revised. So not just the health budget was revised during this time, but the whole national budget. And health has been given, like, Ministry of Health has been given extra funds as an emergency fund to deal with this pandemic. And procurement has gone mostly towards, like, the purchase of PPEs, lab reagents for detection of PCR detection of the virus, the COVID virus, and certain purchase of equipment such as ventilators and things like that. But during this time also, we've seen a lot of companies and private sector coming forward to give a lot of donations, I mean, locally as well as internationally. With I think whole Africa, for instance, has benefited from the JACMA donations going around. But for us, in terms of procurement, we've been having tremendous difficulty because Seychelles is a very small island located in the middle of the ocean, and we depend heavily on airline that comes here to bring the goods. So with the pandemic going on, obviously the whole world has been affected, with the airlines just stopping the travel as we close the borders. So this has been a challenge to get like the usual procurement process to go smoothly. But we've managed to use the national airline, which is the Air Seychelles, to actually fly to different destinations to go and procure, to collect goods, the supplies that we needed. And obviously with the emergency fund available and with current health budget, every procurement process has been fast-tracked so that we could obtain the necessary goods that we needed to deal with this pandemic.
So how do you deal with the issue of accountability during this time where everything is indeed fast-tracked?
So there is what we call the EOC, which is an emergency operating center that was set up nationally to deal with all of these issues. And the emergency operating center, there's like different cells which falls under it. So there's, for example, the planning cells, the operation cells, logistics cells, and it's a concerted effort from these different cells to really find what are the emergency needs needed for the continuity of care, but also for preparedness for the pandemic. So it's a concerted national effort. And in terms of accountability, we have the Ministry of Health, which is twice a week, for example, being interviewed by doing press conferences, on live press conferences where journalists from different backgrounds can ask, whatever questions they needed to ask, and processes are explained. But it's done at a very national level, with also the Parliament being aware of what's going on from both sides to question Ministry of Health at any time in terms of what is being purchased and needed with this pandemic.
And just to add, whatever is required, the invoices are sought by the logistics team, the logistic and operation cell. And once this is sought, the approval for payment has to come from the Ministry of Finance. So in a way, there is certain control from the Ministry of Finance, though it is fast-tracked, but there is always the possibility of being questioned or checked by the Ministry of Finance.
Okay, thank you. Over to the DRC.
Merci beaucoup. Moi, pour la RDC particulièrement, l'expérience que nous avons connue déjà pour 2020 par rapport à la budgétisation, spécifiquement pour le ministère de la Santé, a été orientée vers l'épidémie qu'on avait déjà d'Ebola, que le pays était en train de connaître. Donc, certaines lignes budgétaires ont été spécifiques pour lutter contre l'Ebola, qui était une réalité. Et pendant qu'on est en train de finir de gagner cette épidémie, voilà que Covid vient. Ça nous a obligés actuellement, nous sommes en train de revoir pratiquement tous les budgets de la RDC à la baisse parce qu'il y a beaucoup de réalités qui ont changé. Mais cette révision, heureusement, pour le secteur, ne touche pratiquement pas la santé parce que avec le nouveau contexte qui est presque pareil avec la situation qu'on avait connue avant, nous sommes en train de maintenir pratiquement la situation où les allocations de la santé à son situation initiale de 2020. Donc, tous les autres secteurs sont en train de connaître des coupes, mais la santé est restée pratiquement au même niveau. Nous sommes en train de renforcer les lignes qui ont trait avec tout ce qui a rapport avec la riposte. Donc, l'acquisition des médicaments, tout ce qu'il y a comme un cas pour pouvoir lutter contre l'épidémie qu'on est en train de vivre. Voilà pour les contextes dans lesquels actuellement nous sommes en train de travailler pour la budgétisation contextualisée. Merci.
Thank you. I'll also, one of the questions is on the role of citizens in the budget process. The DRC mentioned in the presentation that it's a vast country and there are challenges in terms of coordinating from the center. So how do you ensure that the needs of the citizenry are accounted for within the budget process, and what types of interaction do you have?
marché, effectivement, le pays est vaste, comme vous l'avez dit, mais actuellement, le processus budgétaire se fait au niveau central. Okay? Mais il y a aussi les provinces qui élaborent aussi leurs propres budgets. De même, au niveau des provinces, il y a aussi les ETD, les niveaux de plus bas qui élaborent aussi ce qu'ils appellent les décisions budgétaires. Alors, dans tous ces processus-là, il est prévu que la participation citoyenne soit aussi prise en compte. Dans les processus budgétaires, tout à l'heure, avec la présentation de M. Nunga, il vous a parlé de certaines étapes qui sont définies déjà par le calendrier budgétaire. Et dans ce calendrier-là, vous avez une partie où il y a des séminaires pour les services d'orientation budgétaire, où vous avez les confessions religieuses qui viennent intervenir, vous avez certains regroupements de corporations qui interviennent, notamment les syndicats, qui viennent poser des problèmes en amont pour que ces éléments soient pris en compte lors de l'élaboration. Voilà un peu comment nous sommes en train de concevoir les choses. Mais l'actuelle loi des finances fait une distinction entre les niveaux de finances. Vous avez le niveau central, vous avez le niveau de province ou des régions, et vous avez le niveau des ETD. Chaque niveau fait des prévisions pratiquement de manière autonome, mais en tenant compte effectivement des ressources qui viennent aussi d'un niveau ou d'un autre. Mais à la fin, vous avez le budget consolidé qui est censé être aussi adopté au niveau du Parlement, qui intègre tous les niveaux et qui donne de manière globale le budget général du pays. Donc, voilà un peu comment nous travaillons. C'est vraiment de manière autonome à chaque niveau. Mais vous avez par moment, il est prévu que les provinces, par exemple, reçoivent des appuis du niveau central en termes d'expertise pour élaborer leur budget, en termes de recettes qui doivent être récoltées, en termes de dépenses qui doivent être effectuées.
Et aussi, c'est avant tout les termes ETD, c'est entité territoriale décentralisée. Ce sont donc du territoire, de chez Péry jusqu'au niveau du village. Alors, à chaque niveau, il y a, par exemple, au niveau central, il y a le Parlement qui intervient pour faire le suivi de l'exécution du budget. De même, au niveau des provinces, il y a l'Assemblée provinciale qui fait aussi le suivi de l'exécution du budget les niveaux. Donc, ainsi, on peut assurer que ce qui a été voté a été exécuté et exécuté correctement. Merci.
Thank you. I'll address my next question to Seychelles. One of the key issues highlighted in the report that is hindering budget monitoring is the lag in receiving information on budget execution. So from the experience of Seychelles, how have you been able to manage this? And what type of impact does it have on the budget formulation stage? Am I audible?
Excuse me, can you repeat the question? It wasn't too clear.
Okay. One of the key issues that have been mentioned or that has been raised in the survey is that there is a significant lag between, in terms of receiving information on the budget. So 3 months, 6 months, 1 month, 7 months to 9 months in certain countries. How has Seychelles been able to manage these types of lags, and what has been the impact of the budget formulation stage?
Well, in the context of the Seychelles, as I've said, we have regular quarterly meetings, but also we have monthly journals on the expenditure from the Ministry of Finance, whereby we can check regularly on the funds used and funds available. And all the different ministries and parastatals, we have a financial controller, which is really an employee of the Ministry of Finance, but they are not based in the Ministry of Finance building as such, but they are attached and are located within the respective ministry. For example, for the Ministry of Health, it is based in the Ministry of Health headquarters, and the FC, the financial controller, are the ones to monitor and direct the payment of the different invoices received from the different agencies of the Ministry of Health, and there is regular feedback on the expenditure via journals. So in a way, Seychelles, we are lucky, I think, being small and having the FCs based within the respective ministry or entity.
Okay, I'll give the floor to both countries to address the final question so that we wrap up. What are some of the short and medium-term investments that African countries should be making in the sector moving forward? What are the short or medium-term investments that African countries should be considering in making in the sector?
Well, I think for the Seychelles, one of our main challenges is the rising non-communicable diseases. So I think there is a need for us to consider different preventive strategies to try and combat the non-communicable diseases, because actually it takes quite a chunk of the expenditure, the health expenditure. Whilst at the same time, we were happy to note in our last NHA that we are increasing in the preventive side. The expenditure on prevention is increasing, which is a good thing. So maybe as advice we can give to other countries is maybe to concentrate more on preventive strategies, or maybe having campaigns such as in Seychelles we had Health of Our Nation campaign. It is a mass sensitization of the population on taking their responsibility for their own health. Actually, we had the theme My Health, My Responsibility, and it was a campaign run not only by the Ministry of Health, but by all sectors at national level. And we also developed the wellness program for workplaces and other preventive strategies such as food and nutrition policies in schools, healthy program to promote activity. So we're trying to invest more in prevention because we will see more.
Thank you, Monsieur Nunga and Monsieur Ntambwe. Final remarks.
Peut-être pour... oui, il y a quelques réponses. Oui, effectivement, pour la RDC, à court terme, on met beaucoup l'accent sur... on investit pour lutter contre tout ce qui est comme maladie épidémique et endémique. Et il y a aussi un programme important sur la santé de la reproduction, de la mère, de l'enfant, du nouveau-né et de l'adolescent, ainsi que nutrition. Et à moyen terme, c'est surtout dans la construction et équipement de formation sanitaire, que ce soit les hôpitaux à tous les niveaux, ou même les centres de santé au niveau vraiment le premier contact dans les communautés. Donc c'est sur ça qu'on est en train de mettre beaucoup d'accent. Quand on parle de construction et équipement de formation sanitaire, cela implique aussi l'approvisionnement régulier en médicaments essentiels, afin que la population qui arrive puisse être soignée correctement. Voilà donc les principaux axes d'investissement à court et à moyen terme pour le moment.
Thank you. I think the Seychelles experience shows really a whole of society approach when it comes to tackling health issues. Investment not only in health, but in other areas such as education. In the context of the DRC, I think in the context of fragility, despite a lot of challenges around capability and sustainable financing, the DRC has shown considerable resilience in the face of the current pandemic, but also recurring bouts of Ebola and other communicable diseases. I think this is all we have for this webinar. Unfortunately, we are short of time. I'd like to take this opportunity to thank our panelists for being with us today and for taking the time to discuss in depth some of their country experiences. I'd like to extend CABRI's thanks to all the respondent countries that contributed to this survey and the wealth of knowledge on how budgeting unfolds in African countries. In terms of moving forward, CABRI will be rolling out a phase 2 of the survey in a bid to garner more insights into additional African countries. This phase 2 will also include more in-depth country work, where we will look at more specific thematic issues that are country specific. In terms of the reports, they will be available on the CABRI website in exactly 1 minute. So please go and download it. It's available, as I said earlier, in French, English, and Portuguese. And thank you to everyone that joined us for this discussion. Thank you.
Thank you. Thank you so much.